So our next speaker is Dr. Laura Miller. She is an assistant professor of psychology and peace studies here at Notre Dame and is also affiliated with our Center for Children and Families. Dr. Miller's research examines the developmental effects of exposure to violence in childhood. With a focus on children who have multiple traumatic exposures, she investigates resulting patterns of resilience and psychopathology, including the development of post-traumatic stress symptoms. Working with an ecological framework, Dr. Miller's research seeks to understand how various systems, like the individual, family, and community, interact to promote or inhibit healthful development following violence exposure. Dr. Miller has a particular interest in the adaptation and evaluation of trauma assessment and treatment as they relate to international conflict settings. So please welcome Dr. Miller.
Okay, hello everyone. Thanks for being here. Today I am going to focus on intimate partner violence specifically. And I'm going to note a few caveats as I go through here just in terms of my area of focus. So intimate partner violence is defined broadly as any threatened or completed acts of physical, psychological, or sexual abuse by an intimate partner. And the lifetime rate of exposure in the United States is between 20 and 35%. And that varies quite a bit across states. And in this particular presentation, I'm going to be focusing on male to female violence, although certainly female to male violence and bidirectional violence exists. Male to female is the most prevalent in the United States, most common form, and it also results in the most injury. So when we talk about childhood exposure to intimate partner violence specifically, these kinds of cases are the most severe and have the strongest implications for children. Also, it's important to think here about our particular cultural context, because I'm going to be talking a lot today about different supports for young mothers and children exposed to intimate partner violence. So we're talking all about the United States here today, because while the effects of intimate partner violence are actually relatively consistent across cultures in terms of psychopathology and effects on family, the societal context and the implications for intervention, how one goes about thinking about intervening in the dynamics of IPV varies quite substantially across cultures. Okay, so what do we know already about who is most at risk for intimate partner violence? This is kind of this graph is a compilation of various studies that have taken into account individual and community factors that are associated with IPV risk and frequency. So we know that these are kind of the three big driving factors of who is going to be violently victimized. So young women, pregnant women in particular, which is going to be the focus of the presentation today, and those with a victimization history. So just to give you a little idea of how prevalence rates vary here, annual prevalence rate of IPV for women is around 2%. So 2% of women in any given year. It's about 4% for women in the youngest age group, 18 to 25. And in surveys that are done on the 9 months of pregnancy, it's about 15%. So really, really high. Okay. There tends to be higher risk for low-income women. And there are kind of questionable, very weak effects for minority women, although some of this appears to be driven by the fact that minority women have more trouble accessing services related to violence and some differences by educational attainment. And then when we look at community level effects, we see that overall communities that have lower educational attainment tend to have more frequent IPV when it does occur, and high population density contributes to more frequent physical intimate partner violence. Okay. So understanding who is at risk gives us a picture of which children are also at risk. And we know that intimate partner violence has a number of very serious effects for children. So in the perinatal period, we know that women and children are at high risk for fetal death, miscarriage, preterm birth, low birth weight, and after birth, time spent in the ICU. The presence of IPV is also linked to higher maternal mortality during childbirth. After birth, we know that women are at particular risk for postpartum depression and for problems breastfeeding, which so many of our presentations today have brought up as a really critical element to early mother and child functioning. So as children progress into infancy, we see some patterns kind of change. Women are at risk themselves for relatively continuous exposure to violence. So in studies that have been done on the duration of violent relationships, the average time spent engaged in a violent relationship is between 8 and 10 years. So we're really seeing that these women and these children are experiencing pretty chronic exposure if they're in this context. And as violence continues, women are at high risk for social isolation. So we see impairment in some of the relational networks that many of you in your presentations have identified as so critical to child flourishing and positive parenting. And of course, lots of mental health effects for moms, including PTSD and depression. We also see children exhibiting effects early in infancy, the beginnings of some PTSD symptoms with exaggerated startle responses, disruption of secure attachment patterns, already some early eating difficulties, and sleep problems. Okay. And then as we move into early childhood, we start to see the presence of higher levels of clinical syndromes, so things like depression, anxiety, lots of early onset behavior problems, very, very high levels of health problems in these young kids, and even delays in things like verbal ability, school achievement, and again, very high rates of PTSD. One study that we did showed that children who were living in homes where IPV was present, who were also being concurrently maltreated or exposed to some other kind of violence had rates of PTSD around 50%, so really high. So that presents kind of a dire picture. So we have been able, and there's been lots of work in these areas on protective factors and resilience. And I myself have worked in graduate school on intervention programs. And my sense, working with these young children and mothers, was that intervention programming, obviously, in the early childhood range is good and important, and we were able to establish some positive effects, particularly for moms. But when we really think about ideas of kind of building resilience versus giving the child an environment where they can really flourish, you know, intervention already in the preschool years is really just too late because these women have already been engaged for a long time in violence, and children are very, very exposed. So thinking along those lines, some of my work here, let me give you the little note that this is very preliminary because these data sets are kind of in collection, asks, you know, if we think about backing up intervention to the perinatal period and catching women before they give birth to children to give them the best chance at providing this kind of positive environment that allows for child flourishing, you know, how can we do that? So some of the questions I asked were, you know, are we doing some of this already? How is it working? And, you know, these are very general questions here, but I kind of sorted them for today into general biopsychosocial framework. So thinking about things like, are women exposed to violence receiving prenatal care? Is it kind of adequate, which is, you know, interesting question in and of itself, I guess. And then in terms of psychological care, are they participating in therapy? Do they perceive it as useful? And is it actually? Because there's been actually quite a bit of work on women exposed to IPV in pregnancy, and there's been almost no intervention that's been able to establish positive long-term effects, although women still rate it highly. So they're like, oh, that was very helpful, but then there's no actual outcome. And so then I was interested in looking, if we think again about how sensitive parenting and mental health are so important to that early parent-child bond, how do we see, even before women give birth, how they feel about the prospect of parenting? And then kind of last in the social sphere, oh, I don't know what this is. I was interested in looking at different kinds of engagements in social networks. So knowing that women exposed to violence tend to be more socially isolated, but that social networks and good relationships are protective for both women and children, how do we think about how women are engaging in these, and whether or not our current interventions really promote that kind of multi-systemic engagement. So, oops, you can see here, right, if we have good prenatal care, we would be hoping for things like more positive birth outcomes for children, better breastfeeding, and competence and preparedness, both for pregnancy and early parenting. Psychological aspects of intervention might help facilitate positive parent-child attachments. And the social network support would help build in some natural infrastructure that might be important for helping women escape a violent situation, and also buffer some of the negative effects of violence for both women and children. Okay, so some of the biological information. So this study, as I said, is in collection. This study is of pregnant women exposed to violence. We have about a dozen who have come in so far. This is a very hard population to track down because they've really got a lot going on. And for women, particularly women who are engaged in kind of the height of a violent relationship, many of them may be kind of on the run or may be unable to participate because of partner supervision. And we've run into both, actually, already in this study. So we collect some kinds of self-report measures from them, and they've also participated in some focus groups, and I'll be showing you a little bit of data from both things today. Just a little bit of information. We do have 8 of our women who have been pregnant in the past, so they give us a little bit of an idea of history of risk. 2 of our 8 women who have been pregnant before delivered children preterm. And so, even though this is a very small sample, this is pretty high risk. This is a high percentage of people delivering preterm, and actually even higher than studies that were done about 15 years ago. 1 out of 8 of these women had at least 1 infant who was low birth weight, and sadly this week 1 of our women miscarried, so we also have a miscarriage as well. So one of the things that we asked mothers who had been pregnant before about in the focus groups was their experience of breastfeeding. And so a lot of them did not have terribly positive things to say about their breastfeeding experience. So a couple of women experienced discomfort, so saying, I tried, it was uncomfortable, I didn't like it, so I switched to bottle feeding. Women reported, problems with the baby latching, and women who had never had children reported a lot of worry about that. So like, what if my baby can't breastfeed? They were talking about that a lot in the groups. Although the good news is that nearly all the women, and we'll see this in a minute, were pretty receptive to information about doctors in terms of their health during breastfeeding. So we saw a lot of women who were using, drugs or alcohol or smoking, stopping that during pregnancy and breastfeeding. But the good news is that the women reported using and liking some of the breastfeeding support groups in the area. So even though they weren't engaging in breastfeeding, they did report those as helpful. Okay, so right before, for these women's current pregnancy, we asked them about some of their feelings and some of their practices in the 3 months before their pregnancy. And we saw that 4 of 12 of them wanted to become pregnant. So we have a fair number of unwanted pregnancies here. Those 4 were taking multivitamins and preparing for pregnancy in some way. Of all the women, 4 were smokers, some of them very heavy smokers. 9 to 12 drank at least weekly, mostly moderate drinkers we've had so far. 75% had seen a doctor or had a regular primary care physician. And this I'm going to highlight only 2 of 12 had been to a safe house or shelter. And this has really clear implications for how services are delivered, because a lot of the thinking is most of our violence services in the area are provided through safe houses, shelters, kind of justice-oriented centers, but this is not really where women are going. During their pregnancy, all the smokers either stopped or greatly reduced their smoking, so that was good, and a lot of them in the focus groups reported that that was information they'd received from their doctors. 2 women were still drinking, 1 or fewer drinks a week. And all of the women were receiving prenatal care, so that was great to hear. But they, in the focus groups, expressed kind of mixed feelings about how that prenatal care was going for them. So one thing that women said was that they didn't really understand some of the prenatal materials that were given to them, or they felt like discussions with doctors were rushed. So one woman said, it's my first time and I know my doctor, but there's things he says and I'll be like, what does that mean? So there's a little bit of confusing, and then the mothers feel stupid or angry or frustrated with their care provider. A number of them also complained about the lack of coordination between service providers, even within the same practice. So one woman talked about going and meeting all of the different doctors in the practice who might deliver her child, and then said basically it's like I was starting from square one, every time I met with someone. Women also said that they didn't feel like doctors listened to their reports of how they were feeling. But on the flip side, they really liked, there were a few doctors and nurses that they said used technology, and they loved that. So they had one provider use Google Hangout check-ins, so the woman could Skype in from home. And a number of them reported using pregnancy health apps on their phone that they really liked. So of these women, only 1 had received a screen through her provider for abuse history. And the one said that she loved it. It was so helpful. It made a huge difference in her pregnancy. And in the focus group, when the other woman heard that, they all reacted very, very strongly. They're like, oh my gosh, that's amazing. I wish my doctor had done that. So it was really interesting to see that women really wanted that, but weren't necessarily willing to disclose that to a care provider unless they had been asked. Okay, so for our first domain, women are accessing prenatal care, so that is good. And there actually seems to be some changes in their health behavior following prenatal care. So they're smoking less, they're drinking less, they're following up with their doctors. But they had a few problems with prenatal care providers in terms of the lack of violence screens and problems in talking with providers. So that leads us to question, right, how much the providers are really remediating risk for violence specifically, even though they're helping reduce health risk behaviors. Okay. So we would hope, right, that all these health risk behaviors facilitate more positive birth outcomes for children, and actually in studies of prenatal care interventions with women at risk, they do, so that's good. But the lack of violence screens leads to significant oversight of environmental risks that are posed to the child, and runs the risk of failing to identify significant mental health problems that can influence early parenting. And then beyond that, right, if you don't necessarily pick up or know that, you are, as a provider, are not really connecting women with other infrastructural supports that might be relevant, like legal social housing services, which again, I'll just say it's really important, right, since most of these women aren't seeking out those services themselves. Okay. In terms of psychological care, this is a larger sample of women who have been exposed to violence in childhood. They are not specifically pregnant, but you see here we have a, oh, I don't know what just happened. Oh, there we go. They are younger, on average, than non-exposed women. And I'm also just going to point out here, these women with a history of childhood exposure to violence, have a rate of exposure to intimate partner violence of about 80% in this sample. So that's just huge. They are significantly more depressed. 50% were over clinical cutoffs for depression, had more physical health problems and more stressful events in the past year. And they had higher early dropout from therapy. So they used therapy at about the same rate as women who were not exposed to violence, but they were more likely to leave it. And although they perceived therapy, they all reported that therapy was really helpful. Past therapeutic experience had absolutely no impact on current mental health symptoms or on violence severity, although it was related to fewer physical health problems, so that's good to see. Okay. And from the study of pregnant women that we're working on right now, we saw that all 12 of our women were above the clinical cutoff for depression symptoms. They had relatively moderate levels of anxiety and post-traumatic stress. And post-traumatic stress and depression specifically, even more so than anxiety, were related to significantly lower levels of parenting confidence. So this measure that we asked them about, said things like, do you feel like you will know how to comfort your baby? Do you feel like you'll know about your baby's sleep? Or do you feel like you'll know how to take care of your baby, if they were to get sick or something like that? And notably, there were some really interesting findings talking to women about their emotional, kind of psychological experience of pregnancy in light of recent abuse. The women were, on the whole, very excited about babies coming, even though many of the pregnancies were unexpected. A number of them expressed fears that their current partner would leave them. And one woman said, she said, because for me, my abuse was in the past, but now you go through this crazy change with your body, and other people are like, oh, you look great pregnant. But I just feel big, nasty, and think, why would he stay with me if I look like this? Because for me, that's how my past relationship made me feel. And interestingly, this came up for a number of women as well. There were a lot of fears about having children who become either perpetrators or victims of abuse, even when women are pregnant. So one woman said, I know I'm having a boy, and I know I went through all of this physical, emotional abuse, and I don't want my son to be like that. I'm so nervous. I've never parented before, and I'm like, I need to do this right because I'll be darned if he treats someone like that. So again, like a lot of fears related to abuse. And then generally, reports of emotionality, crying. Women, half of the women were in therapy in our focus group, and those, again, who were in therapy found it helpful. Although notably, the other half had no interest in ever being in therapy, even though, again, they were all, quite clinically symptomatic. But they said they would be interested in using online or technological interventions because they felt this would get around some of the barriers to care that they identified with money, transportation, and some fears about sharing personal information. Okay. So about 50% of women exposed to violence are using therapy. They think it's helpful, but it is not actually really showing a lot of traction in terms of effects, which leads to questions about evidence-based practice and how we can get violence-specific interventions into kind of the common lexicon of care. And we saw that women who were violence exposed had both higher levels of mental health problems and that these were linked to low parenting confidence and fears about how their parenting might affect children's long-term outcomes in terms of perpetration or victimization. Okay. So some of the implications as we think about kind of promoting or how to tailor treatment to promote mother-child flourishing better is thinking about, how we can use evidence-based interventions and tailor these evidence-based interventions to pregnant women, because there are evidence-based interventions that work for women exposed to violence in reducing depression and PTSD and violence revictimization, but none that have worked in pregnancy. And none of the programs that are currently being used in evidence-based practice have been tailored or tested with pregnant women. So if we can potentially get some traction there, we might, see some positive upswings in parent-child attachment and long-term adjustment for kids. And, interestingly, if we can get, those mental health problems resolved, we might see improvements in maternal warmth, responsiveness, and there is evidence from some work that we've been doing actually in Sweden that early maternal warmth, even in light of IPV, is predictive of positive outcomes in adulthood for kids. Okay. All right, so our last little segment here is in social networks. So in this little pilot study that we're working on, we measured 3 different types of social networks that we hope would promote positive function for women and therefore for children. So we looked at close relationships. These women reported 3 to 8 close relationships, on average 5. And we also gathered data about their participation in online social networks. So their friendships range from 15 to 2,000, pretty broad range there. And we also asked them if they were involved in religious communities, and we had some indices of spirituality and spiritual practice as well. 9 of 12 women identified as a particular denomination. Almost everyone identified as at least somewhat spiritual, but only 2 were actually engaged in any kind of spiritual or religious community. And everyone, actually, that we talked to who was religious but not engaged in a community said, oh, I wish I were, or I'm still looking, I haven't found the right place for me yet. So this is something, women are thinking about. For those women who did have high numbers of close relationships in their social networks, they had more positive health during pregnancy, and this is physical health. So that was really good to see. And there was no relationship that we saw between physical health and engagement in either religious or online social communities. Mental health outcomes were not related to the size or involvement in any type of network that we saw. But right now, this could be due to the fact that we do have a really tiny sample. So anything that would come up as significant has to be pretty large in magnitude. Okay. The one thing that we saw that was kind of both, prenatal intervention kind of care and engagement in a social group was women's involvement in community parenting classes and lactation classes as well. And women on the whole said that, they viewed these very positively. They thought they were very helpful, and they really liked the group-based formats in particular. Although, all of these women, many of them were engaged in parenting classes, but we don't really see very good parenting confidence or self-efficacy in this group either. So there's, again, kind of a disconnect potentially. Okay. So here we saw larger close social networks were related to positive health. And that women generally perceive supports to be helpful here, but there are some kind of important caveats that I'm going to talk about here. So, when women are engaged in these large social networks, we would expect these to have benefits for young children, and this has been borne out in much of the research on IPV in childhood. And, these close networks have positive implications for prenatal health and development. But in this context, it's important to consider that these women that we're working with, we can assume in many ways are socially isolated. So without a comparative sample, it's hard to see, how these women are doing compared to women who are not exposed. So helping women through many means broaden some of their social networks might provide some more generalized benefits for women and children. Okay. And then, overall, we see that access to care facilitates some very positive biological, physical health elements of mother-child flourishing, right? So we saw this with access to both therapy and engagement in prenatal care. But these services are not particularly well integrated, and women may not be likely to use them without having the connections structured for them. And then when we turn to therapeutic mental health care specifically, it's really unclear the extent to which women exposed to IPV are receiving evidence-based intervention, or whether their intervention is even for violence-related issues specifically. And in this group, we notice more early dropout, higher reports of barriers to treatment, and fears about therapy. So these are all really important for us to think about, right, as women's mental health relates to early parenting, ultimately influencing children's long-term outcomes. So getting a very holistic model of prenatal care could potentially be very important for remediating some of these effects. And also, if we think about interventions that can actually reduce the likelihood that women will be victimized in the future, we're actually reducing children's exposure in the future as well. So those kinds of interventions become very, very important. We saw here close social networks, as we've seen for kids, are also really important for moms. We have relatively few women engaged in any kind of religious or spiritual organization. And here there was no evidence of online networking being helpful. And I wanted to make a note here because a number of our women reported use of apps or liking Google Hangouts. They reported very positive affect as it related to online networking. And as our sample gets larger, one of the things I'm interested in looking at is whether there's differences in how abusive partners monitor women's use of online technologies. So we do ask about this. And in our small sample, we have 2 or 3 women who reported, yeah, I'm on Facebook, but, every night my spouse, comes and makes me show him all of my conversations that I've had that day. So, we could see, right, you're probably not going to get a lot of positive benefit from that social outlet if it's being so heavily monitored. Overall, we also see relatively small use of shelter services. So again, this brings us to the need for a really integrated care model for women, where violence screens take place in prenatal care settings that pretty much everybody's using, right? And that coordinators or care providers then coordinate connections to relevant resources that will help, promote positive functioning for women. Okay. I think that's all I got. Questions?
Among your sample groups, did you find much bonding among these women where they could freely talk with each other about their experiences, and would IPV-related social groups somehow be helpful?
Yeah, I think so. So the intervention program that I worked on in graduate school is called the Moms Empowerment Program, and it's a group-based intervention for IPV. And it's been one of the only intervention programs that's been able to show sustained effects in terms of women's violence victimization, so preventing violence in, say, the long term, but 6 to 8 months. So, anecdotally, as somebody who led and worked on those groups, I thought the group-based format was absolutely essential for those women, in part because, they're very socially isolated, so it's kind of a natural built-in social connection that they need. But also, women were at all different stages of their violent relationship in terms of their level of engagement with it. And women who had left the violent relationship provided pretty big challenges for women who were still in it, and really motivated those women to leave the relationships. And that, I think can be done by other women exposed to violence in a group setting in a way that no therapist in a one-on-one setting could really accomplish. So it was very powerful that way.
Hi, I'm wondering if you could talk more about the psychotherapy that they receive. What was done, how long was it, and how did you measure its effectiveness?
Yeah. So in the study that polled kind of women with a history of exposure, we did not get information on the type of psychotherapy they received, in part because I don't know if any of you work as therapists and you ask people what kind of therapy they've received in the past, it's usually like the opposite of helpful information. They're like, oh, we talked. So it's hard to collect that data without collecting it directly from therapists. We did get information about how long they were engaged in therapy, and that was actually interesting because in addition to seeing higher rates of dropout for IPV-exposed women, there was also kind of a smattering across durations. So we had them pick, I was in therapy for less than 1 month, 1 to 3 months, 3 to 6 months. And for women who were not exposed, the time periods they most frequently endorsed were 3 to 6 months, which is a pretty common time frame for the short-term evidence-based treatments, and more than 1 year, so longer, potentially psychodynamic therapies. And women exposed to violence showed no pattern, basically, in how long they were in therapy. So, how that matches up with what they were receiving, I don't know.
What about the perpetrators of the violence, the fathers? Have you had any experience in including them in some kind of,
in some kind of intervention type setting, or?
Yes, perhaps in an effort to not demonize them completely. If the fathers have a disorganized attachment history and the mother has too, the mother is likely to have material be uncovered that she was not previously aware of, and it has repercussions on the father too, and it challenges his rather fragile stress system, and he reacts with violence. So rather than seeing him as some monster who will never engage, but seeing him as a person who has a problem.
Yeah, no, it's a great question, and it's one that I think probably is addressed very differently across different types of couples and also across different contexts. So there's a lot of controversy about including fathers in care for intimate partner violence. If they are the abusive father, very few places do it, very few shelters will even let them enter to participate in any kind of care. That's changing a little bit more now. But I would say commonly, couples who are mildly violent, therapists do tend to engage fathers more in care. And especially actually in the Nordic countries, violence tends to be mild and more gender balanced. So there's a bigger push there for family-based care. But in couples where violence is severe and unidirectional, the extent to which the father should be involved in terms of how it poses a risk to the woman's safety and the children's safety is a hot topic, and not very many people do it. Yeah.
Sorry, I have a question over here, not at that mic. I was wondering if you could comment on the demographics of the focus group you worked with, like what community, what type of community it was, the age group maybe, and also how you recruited those women, and also how, if you collected data on how those women usually accessed or found access to different counseling treatments.
Okay, yeah, I can tell you a little bit about that. So our focus groups are about an even split, white and African American, and our sample is, more broadly as well. That tends to be typical, I would say, in violence-exposed samples. And in terms of how they got connected with their care, I don't know. In terms of prenatal care, a lot of them were connected through Women Infant Care and the Women's Care Center here in town. So they went there for their initial appointment. All of these women in our study are low income, so those are places that serve low income women and then they directed them to, OBGYNs in the area. In terms of therapeutic care, I'm not sure how people got connected, but it's a good question.
I had a question. Could you say more about, were you able to look at family of origin of the people in your study? Until recently, women who were pregnant were surrounded by their older women who had lots of experience and provided support. Mm-hmm. It's great that they have their peer support, but it's not quite the same thing because there are a whole bunch of novices together, and novices, just don't do well without some kind of expert or more experienced, wise person to assist.
Yeah, it's a great question. So a lot of these women tend to be living with members of their family of origin. But in previous studies, and we've never actually empirically looked at this, although it would be a good question, and in groups, we've seen, a lot of fragmentation between women and their families of origin because of issues of past abuse in those families, and particularly for women who come from higher socioeconomic backgrounds, a lot of stigma that's coming from the family of origin associated with their abuse experience. As that is relevant to, maternal child flourishing, certainly repairing those relationships and finding a safe space for women to connect with their families in a positive way would be really important, I would think. Other questions?
Hi. I was just curious if there's any sense of how or if you could increase the parental confidence, if it would, with your interventions, if that would change the long-term outcomes.
Yeah, that's a great question. So some programs that I've worked on have been able to improve positive parenting skills. But again, these are in mothers who already have children. So I would view it as really, really critical that, as interventions are tailored to the context of women experiencing violence in pregnancy, that is an area of primary focus. And again, I think, I know some of the other presenters have talked about this, kind of the importance of having women have a sense of self-efficacy, like they know the information themselves, and it's just a matter of kind of drawing it up and focusing on it. I actually think a group format for that is also really important because women can kind of, teach each other their own observations and kind of debunk some of each other's fears about, the futures of their children and all of that. Great question.
Any last questions? If not, thank you very much.
Okay, thanks.